Good afternoon, all. Dr. Akash Patel, presently working as a medical oncologist and director at Oncowell Cancer Hospital and at Shalin Cancer Hospital. Sir did his DM in medical oncology and hematology from GCRI Ahmedabad and fellow in immunotherapy and target therapy from MSKCC New York. Welcome, sir.
Okay, so on World Cancer Day, that will be coming on 4th Feb, and so we will celebrate this not as the day, but we'll celebrate as the week, and for that we are organizing this webinar for educating our family physician doctors. So for that, my today's topics will be on practical approach for hematological disease and cancer. So first of all, we should should know about when to suspect the hematological disease. So the utmost important thing is clinical history. In any case, whether we will talk about hematology or any other medical field, the history is utmost important in each and every case. So when we see this type of skin lesions like petechiae or purpura or ecchymosis, then always keep in mind that there may be some underlying blood disorder. So if we find this type of petechiae ecchymosis, then do examine the patient thoroughly and do palpate spleen. If we find splenomegaly or palpable lymph nodes are there, then we have to check our CBC report. So when to check CBC report? So we have this type of clinical history and examination. So the main important thing will be here is CBC abnormality. So there are three parameters. We all know that hemoglobin, WBC, and platelets. So these three, apart from these three, there are many other factors what we can keep in mind. Like this is hemogram of one patient which show that WBC in normal range, but hemoglobin is little bit lower, that is around 9 HB, and platelet count is also lower. So anemia with thrombocytopenia. But not only these three things, but we have to keep in mind about the hematocrit level, MCV level, and red cell distribution width also. So this is the again another slide showing the CBC report of other patient in which the WBC counts are very high, 304,000. And if we see that 304,000 counts are very high and which will be suggestive of leukemia only. So again, apart from leukocytosis, here anemia is also the component as we can see. So another CBC report in which hemoglobin is absolutely normal, that is 13.5. But again, the WBC count is 42,500. And predominantly lymphocytes, 87%. So it can be the leukemic involvement also, like a chronic lymphocytic leukemia. So these were all about the only some highlight about the how to read the CBC. But the most important thing when we see the patient is peripheral smear examination. And if we see any abnormality in WBC or platelet, then always try to spare or avoid the steroids. Because what happened in evolving leukemia or the acute lymphoblastic leukemia type picture, when we give steroids, there will be some temporary remission and we will miss the early diagnosis of that patient. So always keep in mind. Again, the transfusion of PCV only if the hemoglobin is less than 7 gram, or the platelet transfusion will be if the platelet count is less than 20,000. So what are the causes of low hemoglobin, that is anemia? So we all know about the commonest causes like iron deficiency, megaloblastic, then some autoimmune hemolytic anemia, then sickle cell anemia, thalassemia, anemia of chronic disease, occult GI bleeding. But apart from that, some oncological, hematological disease are there like myelodysplastic syndrome, leukemia. So these can be present as low hemoglobin. So if we find high hemoglobin, so when the hemoglobin is more than 16.5, we should look for the hematocrit. As I mentioned earlier also in the CBC, that we have to be careful not only hemoglobin and WBC and platelet, but we should check hematocrit, MCV level and racial distribution width also. So if we find hematocrit more than 48%, then it may suggest the patient may have polycythemia and we do require bone marrow examination. So after hemoglobin, so what are the causes of low WBC and what are the causes of high WBC? In low, common cause is megaloblastic anemia. We all know it can present for as like pancytopenic picture also. Apart from megaloblastic, leukemia, myelodysplastic syndrome, multiple myeloma, autoimmune cytopenia, and sometimes in typhoid and dengue, the WBC will be in lower side. So when can we find high WBC, like more than 11,000? So apart from infection, leukemia, multiple myeloma, and leukemoid reaction, and in some viral infection, viral fever, lymphocytosis, the lymphocyte predominantly were found. So what are the causes of low platelet, that is thrombocytopenia? So many times we find pseudothrombocytopenia also. Dengue and malaria are the commonest cause, we all know. Apart from that, immune thrombocytopenia, acute leukemia, myelodysplastic syndrome, and multiple myeloma. These are the disease where we can find low platelet count. For high platelet count, essential thrombocytosis, sometimes reactionary in infection, inflammation, and iron deficiency, we can find high platelet count. So after the overview, so if we talk about detail for the patient in the history, these are the some points to consider in our history always, like age, children or the elderly age group. So some of the disease will occur only in childhood, and some are common in elderly age group, like CLL, chronic lymphocytic leukemia, will be we will see only after the age of the 50s. So again, sex, male and female is very important. The duration of symptoms, the history of bone pain, fever, night sweat, malaise, weight loss, bleeding from any side, jaundice, joint pain, rashes, any radiation exposure or exposure to toxic chemicals, any drug intake or the blood transfusion history, dietary history, and occupational exposure also important. So after history, these are the points to consider in our clinical examination, like the stature of the patient, the dysmorphic features like abnormal thumbs or abnormal limb, then pallor, jaundice, lymphadenopathy, edema, stomatitis or cheilitis like tongue, some nail dystrophy or leukoplakia, skin pigmentation, oral candidiasis, petechiae, purpura, then gum hypertrophy, hepatosplenomegaly. We should always look for the liver and spleen as our clinical examination. So after getting clinical examination, the common and usual and the important aspect in hematology is CBC with retic count and peripheral smear examination. And apart from that, some specific investigation and bone marrow examination biopsy. So in our routine OPD, we always encounter with the patients with pancytopenia sometimes. So how to approach this kind of patient? So when we find pancytopenia in our CBC, always do peripheral blood smear and reticulocyte count. And apart from that, liver function test, renal function test, vitamin B12, folic acid level, viral serology, autoimmune profile, and then for the bone marrow aspiration and biopsy. So what kind of abnormality or the clues in peripheral smear in these kind of cases we can see? Like in if we see the normocytic normochromic anemia, then and also there is no sign of anisopoikilocytosis or no NRBCs or reticulocytopenia, then it may be the feature of aplastic anemia. Macrocytes, we know about the megaloblastic anemia. Again, hypersegmented neutrophil in megaloblastic. Teardrop cells and left shift to WBC infiltrative disease, look for the bone marrow. Sometimes we find activated lymphocytes and reactive lymphocytes. There may be chances of viral infection. Dysmorphic RBC or hypogranular neutrophil, pseudo-Pelger-Hewitt anomaly, then it will be the suggestive of myelodysplastic syndrome. Presence of blast, leukemia. So if we talk about our bone marrow examination, how to do bone marrow examination, it is quite simple diagnostic test, minor bedside procedure, and it will be done in the local anesthesia. No specific diet preparation required, and the patient can go home walking after just 30 minutes of the procedure. We routinely do in our OPD basis. So these are the position for the bone marrow examination. We do from the posterior superior iliac crest, the biopsy. So if we find hypocellular marrow in bone marrow examination, then there is possibility of aplastic bone marrow failure or myelofibrosis. For normocellular, myelodysplastic syndrome and infections. And for hypercellular marrow, it will be suggestive of megaloblastic, leukemia, lymphoma, or some kind metastatic, sometimes metastatic deposits from other solid tumors like breast cancer or lung cancer or other solid tumors. So after having this basic thing about the hematology, we will discuss about some cases. So the cases are very simple. The first case is like 30-year-old male. When this type of patient present into our OPD with malaise, tiredness, and weakness. So these are the common symptoms when the patient is came to our OPD. Always ask about the addictive profile. The patient is alcoholic, and so his tongue was like this. So there is leukonychia and there is stomatitis also. So when we see the CBC report, the anemia, leukopenia and thrombocytopenia. So pancytopenic picture with low reticulocyte count and MCV. MCV is 110. So MCV is again important in pancytopenia picture. And if we found high LDS, then again C for the peripheral blood smear. If we find macroveilocyte hypersegmented neutrophils, then the diagnosis will be, yes, pretty sure, role of B12 estimation and folic acid. So always check about the B12 and folic acid. So it will be the megaloblastic anemia. So we treat with IV B12 folinic acid. There is no requirement of PCV transfusion unless there is signs of cardiac failure. So in case 2, so this gentleman, 18-year-old male, present with the pallor and dyspnea. Also in clinical examination, petechiae and some minor infective component were there. But on physical examination, there were no hepatosplenomegaly or liver and spleen were not palpable. Again, pancytopenic picture, same CBC like the previous one case, but here MCV is 80, whereas in previous case, the MCV was 110. So 110 is suggestive of megaloblastic anemia, but if we find MCV in normal range, and if the PS is suggestive of normocytic normochromic, so do bone marrow biopsy in this type of cases, because in this type of cases we can find hypocellular marrow. So it will be suggestive of aplastic anemia. Yes, so we can treat with triple immunosuppressive agent like anti-thymocyte globulin along with L-thrombopeg and cyclosporine. And if the patient can get a family matched donor, then he can also have also be treated with the bone marrow transplantation. So coming to the case 3, a 72-year-old male presented with fatigue, back pain, the X-ray spine, which we do usually in our OPD. So it was suggestive of some vertebral fracture. We did our routine CBC report. Anemia was there, but the platelet count and WBC are normal. See the MCV, it is also normal, but the renal function, there is renal dysfunction, creatinine 3.2, albumin is low, so calcium is high. So always remember about the CRAP features. High calcium, C4 calcium, then renal dysfunction, anemia, and bone fracture or bony lytic lesion. So when there are CRAP features are present, always look for the serum protein electrophoresis, and we did that and we find AMBEN positive. So it will be the multiple myeloma. Yes. So we know that multiple myeloma can present to our routine family physician also, but apart from that, or because of the back pain and renal dysfunction, it will present to orthopedic doctor and nephrologist also. So coming to our last and fourth most case, the very interesting case, 78-year-old male with the previous history. So again, the previous history is very important in each and every case. He was diagnosed as prostate cancer, post-TURP, post-definitive radiation to the prostate 2 years back when he was presented to our OPD. So, and then he had normal PSA value every month thereafter. But he developed or he presented as febrile pancytopenic picture to our OPD during COVID-19 pandemic. So again, the viral infection can always also have pancytopenic picture in with the fever. So 5-day history of fever, cough, 1 episode of hemoptysis, and shortness of breath along with the fatigue. So we did CBC and there was 8.7 hemoglobin, 1900 WBC and 10,000 platelet. But there were few activated atypical lymphocytes. So we did COVID-19. It came out to be positive with moderate viral load on day 5 of illness. Serum PSA level again normal. So even I have discussed about the hypercellular marrow in bone marrow examination report, that the metastatic deposits from solid tumor like prostate cancer may involve the bone marrow also, and it will present like pancytopenia. But here PSA was normal, so again it was against the that prostate history. There was high CRP but normal LDH and B12 level. Okay. So due to this atypical lymphocyte, we have to do bone marrow examination. And so it may be suggestive of leukemia also. But the leukemia, the peripheral smear was suggestive of abnormal cell, and in bone marrow we find 90% of promyelocytes and with multiple horrors. So we did flow cytometry. There was APML, acute promyelocytic leukemia in 78-year age with COVID-19 positive with previous history of prostate cancer. But again, with the advance of science and with the therapeutic intervention, we did our other reports like fibrinogen level, D-dimer. Always treat the APML as oncological emergency. So because there are only 2 or 3 hardly emergency in oncology, APML is one of them. And we treated this patient with ATRA and ATO combination along with the daunorubicin. There may be some features of differentiation syndrome that will be the because of ATRA. So we have to be very careful and we have to explain the patient about the critical situation, about the bleeding and thrombotic event, both can happen. Along with that, we have to transfuse PCV, PRC, fresh frozen plasma and cryoprecipitates also. So when to diagnose cancer, always remember that it is not only the clinical diagnosis, it is not radiological diagnosis, and it is not serological diagnosis. It is always pathological diagnosis, and it is a tissue diagnosis. So biopsy is must in almost all the cancers. So from today's my topic, take home message, hematology includes both benign as well as malignant disease. Now many hematological diseases can be treated with oral medicines only. Hematological malignancy are completely cured and patients live normal life in some of the cases. Early referral has the excellent survival. This is very important. Early referral has excellent survival. Thrombocytopenia with ecchymotic patch, refer urgently. It can be APML or it can be other leukemias or aplastic anemia. So high degree of suspicious is very necessary to diagnose the cancer at early stage. So thank you for your kind attention, and you may question me. I will be happy to answer.
Thank you, Dr. Akash. It was a nice and brief lecture, which will be definitely useful to all family physicians. Unknown or undiagnosed pyrexia of unknown origin, some lymphadenopathy, or anything which we have to suspect some hematological disorder also. I would like to ask you about this hemoglobin. Hemoglobin above 16.5. What do you recommend? Any treatment or any what we have to look for, and what observation we have to, or what type of supervision we have to keep to the patient?
So when we find hemoglobin more than 16.5 or more than 17, then always again I will say that history is very important in each and every case. So if the patient is smoker, then definitely he can have this kind of high hemoglobin. So always try to evaluate the history. Apart from that, hydration. If there is dehydration, then we may find high hemoglobin. And apart from that, we have to do other reports like LDH and other peripheral smear examination, and then bone marrow examination as a sole investigation marker to rule out polycythemia vera. And if we find out polycythemia, then we can treat that patient according to the our medical line, that we may offer phlebotomy and then some blood thinners also.
Good afternoon, all dear friends. So today I would like to speak few things about basics of cancer, how to diagnose cancer in early stages, and what a general care practitioner can do or help a cancer patients when they come to their OPD. So first is how to diagnose cancer early. So we have a lot of talks already on specific cancers like breast cancers or head and neck cancer, cervical cancer. So any specific problem, like if patient is having a breast lump or a heavy swelling in the mouth or ulcer in the mouth, they will obviously tell by themselves that this is a problem, you investigate for that. But apart from these, what are the general signs and symptoms when a normal complaint can mimic a cancer problem, or a cancer can be misdiagnosed or is not diagnosed in an early stage? Like any problem which the patient is facing since last 10-15 days and which is not getting treated with a normal treatment, like patient is having cough and you have treated with the normal antibiotic, anti-allergic, cough suppressant, but 15 days have occurred, 20 days have occurred, still patient is not improving, then we should go for a CT scan. Similarly, if a fever is there, low-grade fever is there, patient having some malaise or not feeling well, we have treated the patient for 10-15 days, we have given paracetamol, we have given antibiotics, antivirals, and common flu like seasonal treatment, but still patient is having fever, then we should think of some hematology problem. Similarly, problems like abdominal pain, acidity, constipation, which which on general treatment or on our basic treatment is not getting resolved in 15 days, 20 days, 1 month, then we should not hesitate for asking any investigation like CT scan of that particular area. Now, CT scan facilities is widely available, and it's better to get a CT scan. And if CT scans comes out to be normal, we should be happy, patient should be happy. But if we misdiagnose it or if there is a delay in diagnosis, then it becomes a problem. So now I will say a few things about basics of treatment. So when a patient is being diagnosed with cancer, then how we decide how to go further. So according to a particular cancer, first we decide the stage of the patient. And broadly, cancer you can divide in early stage, you can divide in locally advanced stage, or you can advise in a metastatic stage for cancers. So if it is an early stage cancer, the cancer is limited to the organ from where it starts. Generally, we do a curative treatment. And in that, if the tumor is very small, we go for surgery directly. We remove that part. If in a breast cancer, we remove a breast lump, or in a mouth cancer, we remove that part. In a lung cancer, we can do a surgery. In a stomach cancer, we do a surgery. And on the basis of final histopathology reports, on the final staging, we give adjuvant treatment. If the cancer is locally advanced, then we give chemotherapy first, we downstage the tumor, and then we do the surgery. So after surgery, why do we give chemotherapy? Suppose a patient is being treated early, then why do we give chemotherapy? We give chemotherapy to clear the chances of micrometastasis. So what are micrometastasis? Like the patient, whenever is being diagnosed with cancer, there are already small particles of cancer which are into the blood, because cancer is a short growing disease. So since last 4-5 months from the time the cancer was in the body of the patient, there are small tumor particles which is already spread in the body of the patient. So to tackle that micrometastasis, we give chemotherapy for some duration of time, and that is called adjuvant chemotherapy, and that helps to decrease the chances of relapse. So adjuvant treatment is always for some duration of time, for 4 months or 6 months, and then our treatment is completed. Patient is kept on a follow-up, and whenever disease comes back, then we again treat the patient. Otherwise, that patient is cured of the cancer. Okay, I will tell you later on how this concept is changing of late. First, we discuss newer treatment, then we will discuss how this concept is also changing. So what is chemotherapy, what is targeted therapy, and what is immunotherapy? So the chemotherapy are our conventional drugs which acts on cancer cells. And we all know cancer cells are our normal body cells, but because of some mutations, these cells start dividing very fast and start accumulating, and that leads to cancer cell accumulation. So chemotherapy acts on the cells which are fast dividing, and these are mainly cancer cells, so they kill the cancer cells directly. So chemotherapy, as we know, is a traditional drugs which are being used since last many years, and everybody know about chemotherapy. And what are the newer treatments? One is target therapy and one is immunotherapy. So what is target therapy? We know that all the cancers are because of some mutations. The mutations occur in some tumor pathways, and because of that tumor mutations, tumors start increasing very fast. So if we target some specific mutations, then it is known as a target therapy. And unfortunately, we cannot give targeted therapy in all the cancers. And for all the cancers, target therapy are different. Like for lung cancers, there are EGFR mutations, there are ALK mutations. The mutations occur in EGFR pathways, or mutations occur in ALK pathways. There are different pathways, different signaling pathways for different organs. So the target therapy of lung cancer will not act in the breast cancer, or a target therapy of breast cancer will not help in a gastric cancer. So for all cancers, there are different mutations. And if we are able to identify that mutations, then we can add target therapy in such patients. And apart from chemotherapy, we give target therapy. Generally, most of the times, target therapy is given in advanced stages and not in early stages. Okay. And target therapy, because they are specifically targeting the mutations, so they are devoid of side effects. The general side effects of chemotherapy doesn't occur in target therapy. And that is why we are able to give target therapy for a longer duration of time. Chemotherapy, we have to stop after 4 to 6 months in a stage 4 patient, but target therapy, we can continue till there is a response of the target therapy. And the latest treatment is immunotherapy. So it is, though it is not latest, but why there is sudden increase interest in immunotherapy? Because the patent of the immunotherapy is now going off. As we know, all the newer drugs, when they are discovered by any pharmaceutical company, they are given a patent to market them exclusively for 10 years or 15 years as according to the patent, because there is a lot of money involved in the research of a drug, and that company recovers that cost with the patent exclusivity. So the patent of immunotherapy drugs are going off, and now immunotherapy drugs are available at cheaper cost in India. And what are the immunotherapy drugs? See, in our body, there are check and balances which tackles or which kill the cancer cells. And these check and balances are done by the T cells. There are B cells and there are T cells, which are immune cells. And because these T cells, they kill our cancer cells in early stages. But somehow in a particular patient, these T cells are not working properly. And that is why cancer has occurred in that particular patient. So immunotherapy, the cancer immunotherapy drugs, that regulates our T cell system, that enhances the capacity of our T cell system to fight the cancer. The difference between chemotherapy and immunotherapy is chemotherapy kill your cancer cells directly. They have some side effects also. So that is why we have to give a break after some time. But immunotherapy, that enhances your T cell immunity, and that enhances the body's own capacity to fight against cancer. And we can give immunotherapy for a longer duration of time. So immunotherapy was in the market for last 10 years, but initially it was very costly, about 50 to 60 lakh rupees per year treatment. Since last few years, it came down to around 10 to 12 lakh rupees per month. And now the patent has gone off, and many drugs have come in the market of good Indian pharmaceutical companies like Zydus, like Intas, like Glenmark, when this drug cost is come around 3 to 4 lakh rupees. And in next 6 months or 1 year, this cost will also come down. So that is why these immunotherapy drugs will be used more and more in cancer patients. Now the immunotherapy drugs, they typically started in stage 4 patients. So when we saw that they have a very good response, now these immunotherapy drugs are used more and more in even in a neoadjuvant setting, even in early cancers. And the studies have shown that if you use immunotherapy in early stage cancers, then your results become very good and the chances of relapse becomes very less. So now more and more patients will be given immunotherapy. The indications were there in the market, in the guidelines, but because these drugs were very costly, so we were hesitant to use these drugs. But now as the cost is coming down, we will be using more and more immunotherapy drugs in more and more patients. So this was basic about chemotherapy, immunotherapy, and target therapy. Now, how the treatment is changing. As I told you earlier, that early stage cancer patients, they are directly subjected to surgery. Locally advanced cancer, we give chemotherapy and then we go for surgery. But now the concept is changing, because each and every year we have to give better results. So science wants more cure. We have now come from a palliation, like a cancer patient, there is a cancer, we have to just treat the patient, we have to give few months to that patient, good quality of life. No, we have now come up of that ages. We are now chasing cure. We want to cure the patient of the cancer. And now we are finding newer and newer methods how the cure rates increases. So what now is occurring, like you divide the cancer by the response of the therapy. Like if there is a breast tumor, which is operable, and I operate the patient, and then I give chemotherapy or target therapy or immunotherapy, I don't know whether that drug is working or not, because we are giving drug in adjuvant setting to tackle micrometastases, which are small cells in our body, which we don't know whether our drug has worked or not. We work, if the drug has not worked, we only know when the disease comes back. Okay. So now the newer concept is you give the drug before surgery. So even an operable breast cancer, operable head and neck cancer, operable lung cancer, operable stomach cancer, esophagus cancer, all early cancers, you give drugs first. There are combinations of chemotherapy plus minus target therapy plus minus immunotherapy according to the disease. Then you give drugs for 4 to 6 months. Then you do a surgery. Then you assess. If we have achieved desired response, if the tumor cells have gone away, that means our drug has acted very well. If they have killed large tumors, they have also killed micrometastasis also. So our chance of disease coming back is low. But somehow, if the drug has not worked well, there are few patients you have given drug and at the time of surgery, there is not much response. Some tumor cells are remaining. So in that patients, we give 4 to 6 months of extra therapy, or sometimes we change the drug, and we are able to achieve good results in that bad subset of patients. So in today's era, even if a patient has a operable cancer, many of the times we are giving drugs before surgery, and it is not like we are giving or we are in India giving, it is the guidelines which are suggesting. So word is moving in that direction. If a patient goes to America, Europe, or India, the international guidelines are followed, and more cancer are now treated in such a way that we are introducing chemotherapy or target therapy first, even in a early operable cancer patients. So that was how our treatment is changing in new era. One more thing is, like, we all have told you our points, like you have to treat like this is diagnosis, but how, what help you can do to a cancer patient? Like a cancer patient has come to your OPD with some minor problems, then what to see? First thing, like patient has come to you. Why the patient will come to you? He may come to you with fever. He may come to you with vomiting, with weakness, with skin rashes. Okay. So first thing is you have to ask whether your treatment is completed or your treatment is going on. Suppose this patient is on a chemotherapy, then fever has to be taken very seriously, because we all know chemotherapy causes neutropenia. If the patient is having neutropenia and a fever, then it is a dangerous thing. It is a riskier thing for the life. Then we have to talk to the treating medical oncologist and treat accordingly. But suppose the patient chemotherapy has been completed. He is on observation since last 6 to 8 months. So fever, you have to treat like any other fever. Then you are the better judge, because in a non-malignant patients, treating fever, we don't know the seasonal, how to treat the seasonal fever. That is you are master of that thing. So first you have to ask whether your treatment is going on or it has been completed. So similarly, vomiting, rashes, all these things, first you get to know whether the treatment patient is on a cancer treatment or not. Okay. Now suppose patient is not on any cancer treatment, then you have to treat all the problems like you are treating a normal patient. But if patient is on a chemotherapy and patient comes with fever, vomiting, nausea, and weakness, then what we have to do? So obviously patient is being treated with a medical oncologist, but he has come to you in an emergency, or his oncologist is not available, or medical oncologist is very far away, then patient comes to you with this problem. Basic thing is you have to check the vitals of the patient. What is the blood pressure of the patient? What is the pulse of the patient? Then you have to take the basic blood reports, CBC, creatinine, and SGPT. So if counts are low and if patient is having fever, so it's a medical emergency. If counts are normal, patient is having fever, you can start an antibiotic, you can give a symptomatic treatment, and you can ask them to meet your medical oncologist as soon as possible. Similarly, patient is coming with a vomiting on a chemotherapy and is having hypotension. Then you have to admit the patient, give IV fluids, give basic supportive treatment, and then ask them to meet your medical oncologist. So these checking vitals and checking the basic blood reports are very necessary. And now most of the times the patient is having phone numbers of the hospital or phone number of the medical oncologist. Then after examining the patient, examining his basic blood reports, examining his vitals, you can always call the treating medical oncologist and you can discuss the problem with the that doctor. And sir, do you want any other things to be discussed?
Hello.
Hello.
I think, sir, you have got almost all questions. One more thing is sometimes patient comes with a diarrhea, fever,
Yes,
fever and diarrhea. So do we need to give any antibiotic or only supportive treatment and all that?
Yes, sir. See, sir, there are like it is a very common question. I missed it. Very common symptom. Patient coming with diarrhea on a chemotherapy. So two scenarios are there. One, the patient is having the medications which are known to cause diarrhea, like we give docetaxel chemotherapy, we give capecitabine chemotherapy, which are known to cause diarrhea. And most of the times we told the patient that there are these drugs which can cause increased frequency of diarrhea, and you have to be very careful. So first ask the patient that, are you on any drugs in which your medical oncologist warned you about diarrhea? If yes, then what are these drugs? You can check the which chemotherapy drugs they are on, and you can just type on net that suppose the patient is on capecitabine and diarrhea. Just write two words and there will be like that, yes, capecitabine is associated with high amount of diarrhea. Then you have to stop that drug. Okay. And if the patient is not on these drugs, we have to check, first thing is vitals. This patient is diarrhea with hypotension with fever and CBC counts are low, then we have to give him basic services first, like we have to give IV fluids, injectable antibiotics, and treat and call or talk with a medical oncologist. Suppose if patient is having no low counts, the WBC count is normal and diarrhea is there, and it is 1 to 2, 3 episodes of diarrhea, then you can give just probiotics, good hydration. But if diarrhea is associated with abdominal pain, cramping, foul smell, or 5-6 episodes of diarrhea, and there is tenderness in the abdomen, and WBC is normal, then you can give a oral antibiotic like Ciplox TZ or Rifagat, along with the this antidiarrheal drugs like probiotics and anti-secretory drugs. And tell the patient that if diarrhea doesn't get controlled in 24 hours, then meet your medical oncologist.